Good morning, everyone. We are starting the session. All those who gathered outside, please be seated in the front. On behalf of the organizing committee, I welcome you all to AFPICON Kerala 2025. Now I welcome Dr. Indu Rajiv and Dr. Prashop onto the dais to chair the sessions on dyslipidemia management by Dr. Vishnu B.S. and adult immunization by Dr. Mariam Shabira. Dr. Indu Rajiv is working as critical care consultant and faculty in family medicine department at Luz Hospital, Ernakulam. She is a practicing family physician at Vijayalakshmi Medical Center, Ernakulam. She is also the president of AFPI Kerala Chapter. She has many presentations and publications to her credit. Dr. Prashop N. is a consultant family physician at Vadakara Cooperative Hospital. He is the organizing secretary of this event and also the president of AFPI Kerala North Zone.
Hello.
Shall I start? Okay. Yeah, good morning all. First of all, let me welcome you all to the 9th Annual State Conference, AFPICON 2025 Kerala, in this beautiful city, Thalassery of North Kerala. We have wonderful sessions today. Scientific sessions, quiz, posters, and paper presentations. I request you all to stay back these 2 days and enjoy all these academic sessions. Now coming to the first talk by Dr. Vishnu. Dr. Vishnu is a specialist in academic coordinator, Department of Family Medicine, KIMS Health, Trivandrum. He has done his MBBS from Government TD Medical College, Alappuzha, DNP Family Medicine, KIMS Health, Trivandrum. He is a regional FM 360 coordinator, Spice Route South Asia Region Council, National FM 360 PG coordinator and PG coordinator, Spice Route Movement India AFPI. He is a executive committee member of AFPI Kerala Chapter. He has won the best awards, Best Young Doctor Award 2024, Best Young Doctor Award 2023, and he has been a faculty in various state conferences and academic events. And today he'll be speaking, he'll be giving a talk about this lipidemia management. Over to you, Dr. Vishnu.
A very good morning to the organizing committee and all the delegates who have gathered here. First of all, I would express my gratitude to the organizing team of AFPICON Kerala 2025 having given me an opportunity to open the innings of this conference. So the topic allotted to me is dyslipidemia, when to start, what to target and how to treat. So my presentation will be basically in line with the guidelines of Lipid Association of India 2023, which has been endorsed by the Cardiology Society of India. So dyslipidemia is one of the most important CAD risk factor, and coming to the Indian perspective, India has the highest number of CAD patients, and coming to the proportion, compared to the Western population, CAD develops almost a decade earlier in Indian population, and it is most rapidly amongst the patients who are younger than 40 years. So the lipid management based on LDL cholesterol and non-HDL cholesterol target is crucial to manage CAD in both primary and secondary prevention settings. Coming to the epidemiology of dyslipidemias in India, so there is significant epidemiological, genetic and causal association of raised lipid parameters with ACD events. And in India, if you see, there is increasing population level of total cholesterol, LDL cholesterol and triglyceride. So raised triglyceride is an important and unique feature of dyslipidemia in India. And when it comes to hypercholesterolemia, it is more common in most of the southern states as well as few northern states, and more in urban region compared to the rural areas. And if you see the 2023 ICMR India study, so the LDL cholesterol is more, the total cholesterol as well as the LDL cholesterol, you can see it's more higher in countries like, states like Kerala, Goa, Rajasthan, and in West Bengal. And when it comes to the hypertriglyceridemia or low HDL, it is having an almost similar distribution almost across the country. So I would like to spend few minutes in this particular slide. So the Lipid Association of India have divided the population based on the risk factors into 5 major risk groups. Now, what are the risk factors they have considered? The major risk factors include age more than 45 years in males and more than 55 years in females, current cigarette smoking or tobacco use, high blood pressure, by which it means more than 140-90 millimeters of mercury, and low HDL cholesterol. These are the major risk factors. Now there are some high risk factors, that is family history of premature ACVD, which means a first degree relative having who developed an ACVD event less than 55 years in male or less than 65 years in female. CKD stage 3B or 4, apolipoprotein B more than 130, extreme elevation of a single risk factor. That means packing more than 1 cigarettes per day, or one single value of BP more than 180 by 100. The lipoprotein A more than or equal to 50 milligram per deciliter, patient having metabolic syndrome, NAFL with fibrosis grade 2 or 3, or coronary artery calcium score 1 to 99 and less than 70th percentile. So these are the high risk features. Now there are certain other features which are supposed to have association, but the strength of association is questionable. So they are classified as risk modifiers. Those include the lipoprotein A 20 to 49 milligram per deciliter, impaired fasting glucose which has to be repeated and confirmed, increased waist circumference, HSCRP more than 2 milligram per deciliter per liter, and plasma triglyceride more than 150 milligram per deciliter, or non-fasting more than 175. Inflammatory conditions like rheumatoid arthritis, psoriasis, and spondyloarthropathies, and female conditions like premature menopause, preeclampsia, gestational diabetes, PCOS, high polygenic risk score, air pollution, and HIV infection. All these are considered as risk modifiers. So based on these risk factors, high risk factors, and risk modifiers, they have been classified into 5 major risk groups. If it is a low risk category, they will be having 0 to 1 major ACVD risk factors, and LDL should be in the range of 120 to 100 to 129, non-HDL in the range of 130 to 159, and lifetime CVD risk, which is calculated using a QRIS calculator, that should be less than 30%. So if this is the conditions, they will be classified as low risk group. So coming to the moderate risk group, if there are 2 major risk factors, LDL cholesterol 130 to 159, non-HDL 160 to 189, or low risk group with 1 or more risk modifiers, or a lifetime risk score more than 30%. So in the first group it was and. So if any of the one is present, it comes under moderate risk. Now coming to the next category, that is the high risk group, there should be 3 or more risk factors, or LDL cholesterol 160 to 189, non-HDL 190 to 219, diabetes with 1 major risk factor or 2 major risk factor with 1 or more risk modifier, or any 1 high risk features. If this is the scenario, they comes in high risk group. Now, who are the population that is included in very high risk? So diabetes with a target organ damage, which means macrovascular complication is there. Diabetes with 2 or more ACVD risk factors, calcium score 100 to 299 or more than 75th percentile, 2 or more high-risk features, established ACVD or heterozygous familial cholesterolemia. So all this group comes in a high risk. Now, extreme high risk, if the patient is having an established ACVD with more than one feature of high risk group or calcium score more than 300 or homozygous familial hypercholesterolemia, they come under extreme risk category A. And ACVD with one or more feature of very high risk group, recurrent ACS or polyvascular disease, they comes under category B. And despite good control, that is the LDL level maintaining less than or equal to 30, still having recurrent ACVD, they come under extreme risk category C. Now, having categorized into the 5 different groups, but why is it important is because they have established a target level we need to achieve in all these groups. In low risk group, their recommendation is the LDL cholesterol should be less than 100, non-HDL should be less than 130, and ApoB should be less than 90. And when it comes to the moderate risk, it should be less than 100, 130, 90 itself. But it's an optional choice to have an LDL target less than 70 and non-HDL less than 100. When it comes to the high-risk group, the target of LDL should be less than 70, non-HDL should be less than 100, and ApoB should be less than 80. Very high-risk category, it should be less than 50, 80, and 65 respectively. And almost the same value corresponds to the extreme high-risk category A, but it's optional to have a lower value, that is at 30 of LDL and 60 of non-HDL. Now when it comes to extreme category B, the LDL target should be less than 30 milligram per deciliter, non-HDL less than 60, and ApoB should be less than 50. The extreme category C, the LDL should be maintained at a range of 10 to 15, and non-HDL at a range of 40 to 45. Now, how will you proceed? So you have to send the samples for lipid profile, including ApoB and lipoprotein A. And according to the risk group, you look for if the LDL is more than 100. In the low risk group, you start off with a lifestyle intervention. You follow up for 4 to 8 weeks, and you again repeat the lipid parameters. And still, if the LDL cholesterol is more than or equal to 100, you start on low intensity or moderate intensity statin to maintain a target LDL level of less than 100. And in moderate risk group, so if the value is, if LDL cholesterol is more than 100, you start off with lifestyle intervention with moderate intensity or high intensity statin, and follow up after 4 to 8 weeks. Still, if it is more than 100, you have to add high intensity statin with another molecule like ezetimibe. So target value should be less than 100 and optional to maintain it less than 70. Now the other groups, the high risk group, very high risk and extreme high risk group, all need to be initiated on statin therapy. And the intensity of statin, either low, moderate or high, what is to be used, determines what is the percentage of reduction you intend to achieve. If you're targeting a 30% reduction from the current value, you can start off with a moderate intensity statin. But if you want a 50% reduction from the current cholesterol, LDL value, you have to start off with a high intensity statin. And if you are still aiming at a much higher reduction of around 60 to 65%, you have to combine high intensity statin with ezetimibe. And if the triglyceride value is more than 500, you have to add on fibrates. So at 4 weeks after starting this therapy, you have to repeat the values, and if the target is achieved, you can continue the regime. And if the target is not achieved, still the values are high, you have to add other drugs in the armamentarium. And if triglyceride at 4 weeks is more than 150, you have to add on omega-3 fatty acid, like eicosapentaenoic acid. So repeat the values at 8 weeks again. And still if it's high, remaining drugs we have in the armamentarium are bempedoic acid and PCSK9 inhibitors. That has to be added to so as to attain a target which I have mentioned in the previous slide. Now coming to a patient with diabetes, having no ACVD and no target organ damage, we have to treat them as a high risk category to maintain a target of LDL less than 70, non-HDL less than 100 and ApoB less than 80. So diabetes present, no ACVD, no target organ damage should be categorized as high risk. If there is target organ damage, they should be categorized as very high risk with a target of LDL less than 50, non-HDL less than 80, and ApoB less than 65. So if there's established diabetes, established ACVD, and no target organ damage, they're categorized as extreme category A, And if there is target organ damage in a patient with diabetes and ACVD, they are categorized as extreme risk group category B, where the LDL target should be less than 30, non-HDL should be less than 60, and ApoB should be less than 50. So as I told you, triglyceride is an important parameter coming to the Indian perspectives. The normal value is ideally less than 150 milligram per deciliter, but it's optimal to maintain at a value less than 100 milligram per deciliter. So 150 to 199 is categorized as borderline high, 200 to 499 is high, and if it is more than 500, it is very high. And you have to also note that the fasting value of triglyceride compared to the non-fasting should be, there will be a difference of around 18 to 36 milligram per deciliter. So coming to the management of hypertriglyceridemia, if it is in the range of 150 to 199, you have to measure the LDL, non-HDL and assess the ACVD risk. Start on lifestyle intervention. And if the values increase, you can start on with statin and ezetimibe to achieve the LDL target, along with which you have the achievement of triglyceride target. But if it is in the range of 200 to 400, along with all these things, it's still high, you have to start on with fibrates and omega-3 fatty acid. And if it is the range of 500, that's more than 500, you have to definitely consider the risk of pancreatitis. So along with the lifestyle intervention, that is low-fat diet, avoiding refined carbohydrates, weight reduction and exercise, avoid smoking and alcohol. Along with it, you have to add fibrates, omega-3 fatty acids, and initiate statin as well as ezetimibe. Now, what are the parameters in lifestyle management? You have to have a proper weight management, increase intake of unsaturated combination unsaturated fats, and omega-3 polyunsaturated fatty acid is proved to be beneficial. You have to restrict excess calories, sugars, refined carbohydrates, fried foods, and trans fats while maintaining an ideal body weight. The healthiest oils, that is MUFA-PUFA with a high omega-3 to 6 ratio, which is supposed to be flaxseed oil and canola oil. And the combination of MUFA and PUFA is also said to be a good option. Trans fats should be totally avoided. Deep frying should be minimized. Palm oil should be totally avoided. And replace refined carbohydrates, sweetened beverages, and processed food with healthy grain and fiber. Egg yolk and red meat should be restricted, and the emphasis should be on fruits, vegetables, whole grains, legumes, poultry, fish, and nuts. Alcohol intake should be restricted, and moderate consumption of tea and coffee is permitted. So a healthy calorie distribution is achieved by the reducing carbohydrates to approximately 50% of the total calories and adding some healthy fats and proteins. Now coming to the exercise, sedentary behavior and physical activity are associated with negative outcomes. So moderate intensity physical activity, which should be ideally performed daily or at least 5 days per week to achieve a target of 150 minutes per week. So the exercise program should be personalized to each individual, and resistance training should be done at least thrice a week in addition to the aerobic exercise. So when a person is unaccustomed to exercise, you have to start short duration, mild to moderate intensity sessions and gradually increase every 2 to 4 weeks. One point you have to consider is the interaction between exercise and various lipid lowering medications like statins, which restricts the exercise part from the side of the patient. Now coming to the various drugs in the armamentarium, statins are the drugs of choice of management preferred in almost all clinical conditions like primary prevention, secondary prevention, following revascularization, diabetes in patients with heterozygous familial hypercholesterolemia. The effect is dose dependent and varies with statins. Rosuvastatin and atorvastatin are considered the most potent one. Generally, it is safe and well tolerated, but in some patients, there will be muscle and liver toxicity, which is reversible. So in that case, what you have to do is you have to temporarily stop the drug or reduce the dose and slowly re-challenge with a lower potent statin or even with the same statin if it is tolerated. And one thing you have to note that South Asians and Indians are hyper responders to statins, so the dose required for them will be lower compared to the other population. It is contraindicated in pregnancy and breastfeeding and are not recommended in premenopausal females even planning for pregnancy. So I mentioned about high intensity statin, moderate intensity statin, and low intensity statin. So which are the drugs that come in the category? High intensity statin, which aims to reduce LDL by more than 50%. The drugs are atorvastatin 40 to 80 and rosuvastatin 20 to 40. So moderate intensity statin, which aims at a reduction of 30 to 50%. Atorva should be 10 to 20 milligram. Rosuva should be 5 to 10 milligram. And Simva for 20 to 40, Pitova 2 to 4. And when it comes to low intensity statin, LDL cholesterol targeting less than 30%, you can start with pitavastatin 1 mg. So if there is muscle symptoms associated with statin therapy, you have to look for the symptoms and the CPK level. If it is less than 4 times upper limit of normal, stop statin for 2 weeks, reassess after 2 weeks, and slowly rechallenge and find other causes of symptoms. You have to exclude hypothyroidism, vitamin D deficiency, etc. And if the symptoms are present with CPK more than 4 times upper limit of normal, stop statin for 4 weeks, reassess for the symptoms as well as the CPK value. If it is resolving, you can start with a second statin in a slower dose, in a longer frequency. And if the patient is still having symptoms, you have to start off with low intensity like pitavastatin. And if the goal is achieved, you can continue the same. If not, you have to add on other drugs like ezetimibe, bempedoic acid, or PCSK9 inhibitors. Now, if a statin is given and a patient developed rhabdomyolysis, you have to never give statin again. Now, coming to some other drugs which we are having in our box, ezetimibe is usually combined with statin to achieve the target, as I mentioned in the guidelines. If the patient is statin intolerant, you can give ezetimibe alone, which produces around 15% reduction, or it can be given in combination with bempedoic acid, which produces a 40% reduction. So the next group is bempedoic acid, which alone reduces cholesterol by 25%, and the risk of myopathy is low. The only problem is in few patients you can develop mild increase in uric acid. The other drugs is inclisiran. Inclisiran is a long-acting siRNA that inhibits the transcription of PCSK9. And it is a subcutaneous injection given twice a year, but it is very costly. It's around 38,000 rupees to 40,000 per injection. And it has a 24% lower rate of major adverse events. Now, fibrase, as I told you in the guidelines, for every patient having a triglyceride value more than 500, you are starting off with fibrase. And usually monotherapy offers a modest reduction, and combination of enofibrate with statin in patients with type 2 is found to be effective. And Icosa fish oil is the omega-3 containing molecules like icosapentaenoic acid and docosahexaenoic acid. Data are abundant with icosapentaenoic acid to be effective in cardioprotection. And bile acid sequestrants, they are supposed to reduce serum cholesterol, LDL cholesterol by 20%, but not usually used as a monotherapy, but combination therapy is used. And it is the only lipid-lowering class that is safe for women planning pregnancy or lactation. Now, PCSK9 inhibitors, the new molecules, not newer, it's almost more than a decade. Evolocumab and alirocumab, they reduce the LDL receptor clearance, increase hepatic LDL receptor density, and evolocumab reduce LDL cholesterol by 50 to 60%, generally well tolerated without any side effects. Subcutaneous injections either given 140 milligram every 2 weeks or 420 milligram once a month, and the cost is coming around 18,000 per injection. Now, some newer molecules like lomatipide and ipomycin, and these are not routinely used. There is a risk of hepatotoxicity. Now, what are the reasons for non-adherence and strategies to improve adherence? The common reasons for declining or discontinuing the therapy are cost, fear of actual or perceived side effects, and conflicting opinion regarding the risk-benefit ratio. The statin can cause muscle pains, while non-statin can cause GI side effects, injection site reaction, influenza-like symptoms, and nasopharyngitis. So factors such as polypharmacy, lack of understanding, and misconceptions and media coverage affect the adherence. So we have to address these factors, and better patient education and empowerment are crucial to improve the adherence to lipid-lowering therapies. So use of technologies and artificial intelligence, guided therapy, adherence prompts, and patient education and empowerment can significantly improve adherence. Now coming to the conclusion. So effective lipid lowering through non-pharmacological and pharmacological means is one of the most important strategy for ACVD prevention. The selection of modality and intensity of lipid lowering therapy and identification of treatment target depend on the patient's future risk of developing ACVD. Hence, an accurate assessment of risk is an essential first step to guide in treatment. The updated risk guidelines algorithm helps the clinician to set an appropriate lipid lowering treatment regimes, optimize the goals and comprehensive risk reduction in patients, and thereby improving cardiovascular outcomes. Although these recommendations provide solid guidance for CV risk assessment and lipid management, The clinical judgment and shared decision making remain very important at every step in applying these recommendations in clinical practice. Thank you.
Thank you for that elaborate session, Dr. Vishnu. The question for the session will be entertained after the second session, together for both the sessions. Now I welcome Dr. Mariam Shabira for her session on adult immunization, essentials for family physicians.
Hello, good morning all. First of all, welcome to Thalassery for the AFPICON. Okay, we have first talk was wonderful. So this is our second talk. It's about adult immunization. We have presenter Mariam Shabira. She completed MBBS, MD and DNB in family medicine from Government Medical College, Kozhikode. Now working as a senior resident. Currently working as family physician, chief medical officer at ICRA Dispensary, Indian Institute of Management, Kozhikode. And now also a faculty in Department of Family Medicine, ICRA International Hospital and Research Institute, Kozhikode. Welcome.
Good morning all. Respected seniors, my dear friends and colleagues, my topic for discussion is adult immunization. First of all, I thank the AFPI team for giving me this opportunity. So as family physicians, we are the first point of contact for any healthcare issues, health-related issues. So that includes immunization also. So as family physicians, we should have a thorough, deep, updated knowledge regarding the immunization also, whether it is pediatric or adult. So moving on to the topic, immunization is one of the most economical public health measures that protect the community by halting the transmission of infectious diseases in addition to the individual benefits of immunization. So India has had a well-defined pediatric immunization, as we all know, that is active since 1978, and it is one of the biggest vaccination campaigns in the world and is called the Universal Immunization Program. But unfortunately, the adult vaccination is an area that is greatly neglected. What is the relevance of adult immunization? Because of the increase in the life expectancy and more accessible healthcare, there is an increase in percentage of elderly population. And there is an age-related immunosenescence due for the infections that are preventable in the childhood due to childhood vaccination. And there is an increase in prevalence of chronic diseases, and people are traveling across the globe for many reasons. What are the benefits of adult immunization? It reduces the burden of the disease in the most productive, vulnerable working age group, and it reduces the incidence and prevalence of the disease in the general population too. And more vulnerable population will get better protection due to targeted immunization. So what are the challenges? The most important challenge is the cost of the vaccine itself, as we don't have a government supply, and lack of knowledge and awareness regarding the efficacy and benefits of the vaccine, and doubts regarding the safety also. So we hope it should be included in the adult immunization program, also should be included in universal immunization program. And it should be included under reimbursement programs in insurance scheme, whether it is private or public. So moving on to the recent recommendations, we have Advisory Committee on Immunization Practices, ACIP, latest guidelines and CDC. But because of the change in the prevalence of the disease and the availability of vaccines, we should have our own indigenous recommendation. That is Association Physicians India, API guidelines. So API has introduced a recent guideline from February 22nd, 2024, and we have recommendation from the CDC ACIP for 2025. So what are the vaccines recommended? These are the vaccines recommended in general for adults and specifically for the travelers. Moving on to the immunization, vaccines proper. First is hepatitis B. It is a recombinant DNA plasma-derived inactivated vaccine which is given as deep IM, 1 ml, 3 doses at 0, 1 and 6 months. Revaccination is recommended every 5 years for high-risk individuals, including healthcare practitioners. So it is recommended for all individuals. If there is additional risk, more than 50 years also, it is recommended. So chickenpox vaccine, it is a live attenuated vaccine which is given as subcutaneous, 2 doses, 0.5 ml at least 6 to 8 weeks apart. It is a highly efficacious vaccine up to 98%, and it is given as 2 doses, and if it is incompletely vaccinated, we can give 1 dose only to complete vaccination, whether it is late vaccinated or vaccinated in the proper time. And it is routinely indicated, especially for healthcare practitioners and family contacts of immunocompromised individuals. It is given as post-exposure prophylaxis also within 3 to 5 days of exposure. So it is recommended for all adults and not recommended more than 50 years, and immunocompromised, it is absolutely contraindicated. Moving on to Tdap vaccine, it is a combined vaccine with toxoid and acellular pertussis vaccine. If it is TD, it is a toxoid vaccine only, and route of administration is IM, 0.5 ml, and it is given as every 10 years. So if it is an unvaccinated individual, we have to give first dose as Tdap vaccine, it is preferred, and second and third vaccine at 1 and 6 months respectively, and later Tdap every 10 years. And in pregnancy also, 1 dose should be Tdap vaccine, it is preferred. And post-exposure to a wound care management, if it is more than 10 years, if for a clean minor wound, you have to give a Tdap booster. And if it is more than 5 years also, if it is a tetanus-prone injury, we have to give a booster dose. And if a person has taken less than 3 doses only, we have to give immunoglobulin, plus we have to complete the vaccination. Otherwise, this scenario will repeat again and again. So we should advise the patient to come for the following vaccinations. So whether Tdap or TD, both are indicated for all adults, but for the first pregnancy, 1 dose of Tdap is preferred over TD. Moving on to Hib vaccine, it is a lyophilized conjugated vaccine. It is also available as combinations too, and route of administration is IM, 0.5 ml, 1 dose, and for hematopoietic stem cell transplant patients, we have to give 3 doses irrespective of the previous vaccinations. So it's also a part of primary immunization in children, and in adults, we are giving it for immunocompromised individuals, CSF leak, trauma and all, and age more than 50 also. And if elective splenectomy is planned, we have to give it as 1 dose at least 14 days before the procedure. In hepatitis A vaccine, we have live attenuated vaccine and the killed vaccine also. For killed vaccine, it is 0.5 to 1 ml. We have to check the manufacturer's instructions for that. And it is given as 2 doses, 0 and 6 months. And for the live vaccine, it is a single dose, 0.5 ml sub-Q. We have a combined hepatitis B and A vaccine also. So for that, we have to follow hepatitis B schedule. So hepatitis A is indicated for travelers and chronic liver disease, alcoholic, chronic hepatotrophic infections like hepatitis B and C. And for travelers, we have an accelerated schedule also with 0, 7, and 21 days, followed by a booster at 1 year. But CDC recommends for any person who is not fully vaccinated and requests vaccination, irrespective of the risk factor, we have to give a complete 2-dose series of hepatitis A. But the cost of the vaccine for hepatitis A, Biovac A is a live vaccine. It costs around 2,200 rupees, and hepatitis A killed vaccine costs 2,300 rupees. Moving on to HPV vaccine, we have quadrivalent HPV vaccine and nonavalent HPV vaccine, and India's own Cervavac, that is a quadrivalent vaccine which is produced from Serum Institute of India. So dosage and schedule, it is an intramuscular vaccine, 1 ml, 2 to 3 doses. If it is less than 14 years, 2 doses only, 5 months apart, and more than 14 years is 3 doses, 0 to 6. And it should be given before first sexual encounter. The quadrivalent vaccine costs around 4,000 rupees, and the nonavalent vaccine costs around 10,000 rupees for a single dose. Moving on to influenza vaccine, it is an inactivated influenza vaccine. Recombinant, trivalent or quadrivalent vaccines are there. Route of administration is 0.5 ml IM annually. Quadrivalent vaccine include influenza A H1N1, influenza A H3N2, influenza B Victoria and Yamagata lineage. And there is a live attenuated vaccine also there that is given as intranasal route. So from March 2020, there is no Yamagata infections reported. So we have to prefer on trivalent vaccine, but we don't, in India, we don't have a trivalent vaccine available. CDC recommends trivalent vaccines only, but we don't have that vaccine in India. And there is a difference in schedule in southern hemisphere and northern hemisphere. For the southern hemisphere, that is for us, it is given in April and May. And for northern hemisphere, it is September to November. The single vaccine costs around 2,400 rupees. So the inactivated vaccine is recommended for all adults, including healthcare practitioners. Moving on to MMR vaccine, it is a live attenuated combined vaccine which is given as subcutaneous 0.5 ml, 2 doses, 4 weeks apart. And it's strongly recommended in healthcare practitioners and international travelers, and it is also given as a post-exposure prophylaxis. As a live vaccine, we have to have precautions in patients with moderate to severe acute illness, and if there is any blood or plasma or IVIG given, history of thrombocytopenia or thrombocytopenic purpura, and it is absolutely contraindicated in pregnancy and severe immunodeficiency, and it is not recommended above 50 years. But if a patient is pregnant within 1 month of MMR vaccine, it is not a indication for doing MTP. Moving on to meningococcal disease vaccine, it is we have polysaccharide vaccine and conjugate vaccine available, which is for ACVWY serotypes only. So there is a serotype MIN B also, but it is not available in India. And route of administration for polysaccharide vaccine is subcutaneous and conjugated vaccine is IM. And both the dosage is 0.5 ml. So for high-risk individuals with anatomical or functional asplenia, HIV infection and all, we give 2 doses 8 weeks apart. But travelers and gatherings and all, we give 1 dose only. Similarly, pneumococcal disease also, we have polysaccharide and conjugate vaccine. Polysaccharide given as sub-2 and conjugate vaccine we give as IM 0.5 ml. So we have PCV 13, 15, 20, 21. The CDC recommendation, ACIP recommendation is PCV 20 and 21. For that, we don't need any booster dose at 1 year. But PCV, we have only PCV 13 available in India. So in India, we give 1 dose of PCV 13 followed by PPSV 23 1 year later. So it is recommended in all adults, especially more than 50 years. Initially, it was 65 years. Now it is 50 years. And the cost of the conjugate vaccine is around 4,000 rupees. And the pneumovax, it is adult PPSV 23, it costs around 2,300 rupees. Moving on to rabies, we all know the schedule and vaccines, all these things we all know. We are just brushing up the practical points only. The pre-exposure prophylaxis is 07, 21 to 28, and the post-exposure is 037, 28 for intradermal, 0.1 ml in 2 sites, and 037, 14, 28 as IM 1 ml. And if it is a re-exposure, we give single dose, whether it is IM or ID, on day 0 and 3. And there is no need of any immunoglobulin, irrespective of the category of the wound, if it is a re-exposure. And if it is less than 3 months, there is no need of any vaccination also. And immunocompromised individual, we give IM dosage only. And for category 2 and 3, we have to give immunoglobulin. And this is a very common scenario. At least 3 doses of the vaccine should be given within 10 days to get an adequate immunity. And the type of the vaccine should not be changed as possible. And for elderly, post-exposure is 5 doses only. And there is a immunoglobulin, which is rabies human monoclonal antibody instead of the human immunoglobulin. which is the dosage is 3.33 international unit for category 3, and the 2.5 ml is 100 units. So in ml it is 0.083 into body weight. So 2.5 ml of rabies shield costs around 2,000 rupees. Moving on to typhoid vaccine, the commonly available are VI polysaccharide vaccine and the VI conjugate vaccine. Both we give as 0.5 ml IM. We have to give booster every 3 years. So typhoid vaccine is indicated for professional food handlers and travelers into endemic areas. If possible, we have to prefer the conjugate vaccine. The issue is the cost itself. It costs around 2,300 rupees, and the polysaccharide vaccine only 135 rupees per dose. And moving on to shingles vaccine, it is a highly effective vaccine which is efficacy up to 97%, and it's a recombinant zoster vaccine which is given as subcutaneous, 2 doses, 0.5 ml, 2 to 6 months apart, but the cost is around 10,000 rupees per dose. Moving on to respiratory syncytial virus vaccine, it is not yet approved in clinical use in India, but ACIP CDC recommends it's for all adults more than 75 years and pregnancy within 32 to 36 weeks in the RSV season. And Japanese encephalitis is also an inactivated vaccine which is given as subcutaneous 0.5 ml, 2 doses at least 4 weeks apart, and it is also recommended for the travelers. Moving to yellow fever vaccine, it is a live attenuated vaccine with highly efficacious vaccine, and route of administration is IM, 0.5 ml per single dose. It is not routinely recommended, but it is recommended for the travelers to highly endemic areas, especially UK and US for the students. And we have 4 recognized centers only under Government of India in Kerala. 2 centers are in Kochi, and 1 center, the 3rd center is Calicut Medical College, and the 4th center is Government Medical College, Trivandrum. So we have to get a lifetime certificate. It is given only after 10 days of vaccination. So if some patient is planning for a travel, we have to advise them to take at least 10 days before the travel. And poliomyelitis vaccine is also for travelers to endemic areas. And this adult polio vaccine is also available in yellow fever centers only. And moving on to chikungunya vaccine, it's a live attenuated vaccine. It is not approved or available in India now. Cholera vaccine also is a live attenuated killed vaccine which is given as oral 2 doses, and routine administration is not recommended. It is preferred only in the time of epidemic. And there is anthrax vaccine also only for livestock handlers and laboratory workers. And COVID-19 vaccine, we all know the types, all these things we thoroughly know. And it is indicated at the time of the pandemic for all individuals, including pregnant ladies. And it is also 2 doses as 4 weeks apart. And we have to give a booster dose in high-risk individuals with comorbidities. So moving on to general recommendations, we can categorize the adult vaccines into 3 types: vital, essential, and desirable. Vital vaccines include vaccines for critical for public health, targeting diseases with high morbidity and mortality, emphasizing universal coverage to active the herd immunity. And essential vaccines are basically targeted vaccinations for high-risk individuals, and desirable vaccines are for additional health benefits, but they may require individual risk assessment and careful consideration, including the cost effectiveness. So for healthcare individuals, the vital vaccines include Tdap, hepatitis B, MMR, and varicella vaccine, and influenza vaccine is also desirable. Patients with chronic illness, especially diabetes, the vaccines include HPV, Tdap, hepatitis B, pneumococcal. Hepatitis B are vital, and which includes MMR and chickenpox vaccine also. And pneumococcal and influenza vaccines are also should be considered. The meningococcal vaccine is especially indicated in chronic liver disease, chronic heart or lung disease, and splenic infarct and asplenia. And shingles vaccine is especially indicated in diabetes, chronic kidney disease, and cancer patients. And in splenic issues like asplenia or complement deficiency and all, we give Haemophilus influenza type B hip vaccine, meningococcal and pneumococcal vaccine. In immunocompromised individuals, most inactivated vaccines are safe, and most live vaccines like MMR, varicella and all are usually contraindicated. But for HIV infection, if the CD4 count is more than 200, we can consider giving varicella and MMR vaccine. For hematopoietic stem cell transplant, we are changing the whole immunity of the patient to another patient. So the re-immunization process starting from inactivated vaccine at least 1 year after the bone marrow transplantation, irrespective of the previous vaccination. And for solid organ transplant, we have to accelerate all the immunization before the surgery, and after transplant, the live vaccines are contraindicated. So for students traveling from India to international destination, we have to ask them to check the individual's country's immunization recommendation. Generally, these vaccines are always recommended. So MMR for seeking college admission in Europe and US especially, hepatitis A in countries with poor sanitation, and Japanese encephalitis during transmission seasons, and cholera also during outbreaks. So for pilgrims inside India, like Kumbh Mela, for everyone we advise typhoid, hepatitis A and influenza vaccine. And if there is prolonged stay, hepatitis B, JE and pneumococcal vaccine is also recommended. And for Hajj and Umrah pilgrims, for everyone it is recommended to give meningococcal vaccine, it is compulsory, and influenza and polio vaccines are also recommended. So these vaccines are upcoming vaccines. Just to have an idea, this is the India's first vaccine for dengue, and HIV vaccine is also under trial, and there is an India-made leprosy vaccine is also under clinical trial. So thank you.
Thank you, Dr. Vishnu and Sabira. The first talk about dyslipidemia. Any questions? Please stand. You can have only one question.
Sir,
Yeah.
indication of ecosprin in dyslipidemia.
Actually, except for secondary prevention settings, apart from that, there is no recommendation as such for starting ecosprin in the primary prevention.
Dr. Vishnu, is there any guideline for children for checking lipid profile? Any idea?
Actually, I have not come across it.
Okay. I think there is some guideline for children also. In the OP, I think the mothers, when they come, they see.
Yeah, nowadays with obese children.
Yeah. Okay, I think if there's no more question, the next talk, Dr. Shabira.
Even though it's a neglected area, adult vaccination is very important. So Dr. Shabira took very wonderful session. So any questions regarding this?
We usually give the polysaccharide vaccine because food handlers, they are not available for, not affordable the conjugate vaccine, and it should be given in 3 years. Conjugate also 3 years only, but the cost difference is very much. No, both are available in our sector.
I'd like to add a point to what Dr. Shabira said regarding rabies vaccine. You had mentioned that the intradermal schedule 0, 3, 7 and 28, right? So the first 3 doses need to be taken within the first 10 days, but care should be taken that the minimum interval between the doses should be maintained. You can't give it on day 0, day 9 and day 10. That is not possible. The minimum interval between the doses has to be maintained. So that means not more than day 6. The day 3 vaccine cannot be given later than day 6. That is number 1 I wanted to highlight. Number 2 is both IMRV regime and IDRV regime produce similar responses, but IMRV is preferable in immunocompromised. That is not because it elicits a better response, but it's because the technique is more easy. So you don't have to, the human errors are minimized. When you give IDRV, the technique is not perfect. You cannot depend on the response. Thank you.
Thank you, sir.
Both the talks were wonderful. Thank you for the presentation. And we can go for the next session.
The audience may also make use of the Zidbos app in case they have any query regarding any of the sessions, scientific sessions going on. Now moving on to the next two topics. Sorry for that. We're going ahead with presenting the mementos. Now, okay. We'll be presenting the mementos to the speakers, Dr. Vishnu B.S. and Dr. Mariam Shabira. It will be done by the chairs. Now let me welcome Dr. Kailas, the State Secretary, AFPI Kerala Chapter, to present the mementos to the chairs, Dr. Indu Rajiv and Dr. Prashop.
Thank you, Chairpersons, Dr. Indu Rajiv and Dr. Prashop. Now we are moving on to the next sessions. For chairing the next two sessions, I'd like to welcome Dr. Abdul Rasik and Dr. Anand K onto the dais. Dr. Abdul Rasik is a family medicine specialist in Kerala Government Health Services Department, and he also serves as the resource person for training Kerala Institute of Local Administration. Dr. Anand K is a CMO at GH Thalassery in Kerala Government Health Services Department. He is an executive member and faculty of Trauma Care Kannur and advisory board member of Kannur Dementia Care Society, besides being a convener of IMA ELS at Thalassery. For the next session, Masculine Matters, a comprehensive view of male sexual dysfunction, I would like to call upon Dr. Anup KJ onto the dais.
Good morning, all. We are moving to the next session. Our session is masculine matters and about male sexual dysfunction, presenting by Dr. Anup KJ. Completed his graduation from AFPI Medical College in 2002 and completed postgraduate diploma in family medicine and fellowship in diabetes management from Christian Medical College, Vellore. And he's a member of prestigious Royal College of General Practitioners International and an alumni facilitator in CNC Distant Education. Family physician located in Kochi and a medical officer in Kerala Government Health Services. And being an active member of AFPI Kerala, as a treasurer, served as a treasurer in AFPI Kerala and as secretary AFPI Kerala Mid-Zone. Over to you, Dr. Anup.
A very good morning to everyone. And thanks to the organizers for giving me this chance to stand before you and speak on this topic. So, I'll start the story. This is a This is Mr. Albert, who is 50-year-old sales executive, who is diabetic and hypertensive with taking metformin and telmisartan. And he recently attended this clinic with some vague complaints of tiredness. All the tests seems to be fine, nothing to worry. These vitamin tablets will take care of your tiredness. See me after a month, if not better. This is what the doctor said to the patient. Disappointed and with a heavy heart, he left the clinic. Looking back at the doctor once again before he left, he wanted to say something, but he didn't, and he left. Meanwhile, the doctor was smiling back at the patient, confident that he hasn't missed anything, and busy calling the next patient. I hope you all agree with me that the consultation has gone wrong. What was the patient trying to communicate through tiredness? Every patient coming to your OP will have a hidden agenda. And why did the doctor miss to unveil it? So welcome to my topic on muscle matters. Even though you have attended a lot of CMEs on erectile dysfunction, I am going to take a different approach. I am going to have a comprehensive view on all sexuality. So in the next 20 minutes, you will be catered to all these aspects of sexual medicine. So, sexual dysfunction is not rare. Statistics speak for it. But it is neglected because of our attitude. And doctor and the patient have their own excuses for the same. This is the reality. The patient wants the doctor to ask about their health, sexual health, but they are afraid of getting asked. So that creates a contrary situation in the clinical practice. But what happens is that if it's neglected, all these ill effects can occur, and sometimes it can be life-threatening. And this is WHO's definition of sexual health. So a comprehensive multifaceted view is necessary, and it is nothing but to understand the symptom such as erectile dysfunction or ejaculatory disorder in the context of patient's life, addressing all these parameters. Now the part 1 deals with assessment of male sexual dysfunction in total through the eyes of Mr. Albert. So my question is, do all patients need sexual assessment that comes to your OP? Obviously not. But in these 3 situations, it may be required. And can you think about a situation for each of these clinical scenario? Okay. Now, disappointed Albert visited another doctor. His name is Dr. Nadeem. He is very famous in Vadaga. And through 3-stage assessment, he sensed that the patient is trying to communicate his sexual issues through tiredness. But just because the topic is a taboo, the doctor signposted, and that is nothing but warning the patient what he is going to do next and what he is going to do next. And this is how he did it. Most of my patients with diabetes face problems with erection. Do you have any issues? Because it is important there is effective treatment. So once the patient, the doctor is in the track, we should know how to talk about sexual problems. And these are the ground rules. Okay. And this is a normal sexual response cycle, and problems can occur anywhere in this segment. Sometimes it can be mixed. One being the primary and other being the secondary. Last but not the least, do not forget to address the ideas, concerns, and expectations. I agree that masturbation, there is no evidence to suggest that masturbation causes erectile dysfunction. But taking a history on masturbatory practices, incorporating all these details, as well as the category of thoughts and quality of erection and orgasm that occurs during masturbation as well as during sex, and if there is a huge disparity, that can create a sexual dysfunction, and that is known as fiction-fantasy mismatch. Every story has an alternate version. So it's better to know what Mrs. Albert has to say about Mr. Albert's problem. And that can be useful in managing the erectile dysfunction or sexual dysfunction of the patient. Thank you. Now, the primary issue of Mr. Albert was erectile dysfunction, and this is how it is defined. To address to make a diagnosis and assess the severity of the erectile dysfunction, this is a brief questionnaire, and based upon score, you can diagnose and assess the severity. When you take the history of ED, all these things should be covered regarding the symptom onset and duration, the partner history, as well as the degree of sexual function in various modes of sex, including masturbation, various stages of sexual act, and during morning erections. These are the risk factors or causative factors for erectile dysfunction, medical and surgical. And when you assess, you should rule out these red flags which can present as ED. Physical examination focused on ruling out metabolic syndromes, penile deformities, as well as hypogonadism. Investigation, there's not much investigation except lifestyle disorder screening, but fasting morning sample morning serum testosterone should be tested, and it should be repeated if it is abnormal, along with other endocrine parameters shown here. Investigation are not usually needed, but in these subset of patients, it is recommended. So when a patient comes with these type of features, that is a clear indicator that he is having a strong psychological component of erectile dysfunction. And this is a hallmark of ED. A good penile rigidity during periods of foreplay, but as penetration is attempted, erection begins to fade away. The timing is also important. The patient will say sex was great until some life-changing moment, like getting married or birth of first child. These psychosocial behavioral factors in the patient as well as the partner can precipitate a erectile dysfunction or sexual dysfunction. So do the psychiatric disorders. In fact, depression and anxiety has bidirectional relationship with the erectile dysfunction. So screen them when patient present with either of them. Now something beyond the bedroom walls. Canary is a small bird that was used in coal mines in the olden days to detect carbon monoxide before it causes human poisoning. Just like the canary's death, if you detect erectile dysfunction in a patient, that is a forewarning that something sinister is about to happen in the patient's life. That is a cardiovascular risk is high. Because the pathology is same, endothelial dysfunction. So the window period should not be missed. You have to calculate the risk and manage appropriately. Lifestyle disorder and erectile dysfunction has bidirectional relationship. So screen both when the patient is presenting either of them. So the next question is it safe to prescribe oral drugs for Mr. Abbott? And for that we have what is known as Princeton 3 guidelines, and based upon the exercise tolerance, the patient is divided in either into low, intermediate or high risk. And low risk can be treated in general practice without evaluation, and these are the subset of patients that come under this category. Now coming to the management, and before going to management, this is the story so far with regard to Mr. Albert. And these are his ideas, concerns and expectations when he came to Dr. Nadeem. Practically speaking, there is nothing purely physical or purely psychological. It's like in a spectrum. So Albert's erectile dysfunction lies somewhere along the spectrum from physical to psychological ED. So a biopsychosocial approach is needed after making a shared decision between patient, partner and the physician. These lifestyle changes have enormous impact on erectile dysfunction, so should be advocated. And whenever we speak about erectile dysfunction, the first thing that pops up in your mind is a little blue pill known as Viagra, born in 1990s, which revolutionized the sexual medicine. And it acts on PDE5 inhibitor, increases the blood flow to penis and maintains erection. And these are the two commonly used one. And you can read for it the main differences. Advantage of tadalafil is it can be used daily regime, which creates a spontaneity in intimacy of sex that may be more acceptable to patients who doesn't want a programmed sex. These are the other two molecules. Grapefruit is not advised during to patients who are on PDE5 inhibitors, and nitrates and nicotinides are strictly contraindicated because they cause a fatal blood pressure fall, and these precautions also should be taken care. These are the usual side effects. Serious side effects are rare, but priapism can occur. In 70% cases, it will be effective. But if it is not effective, before saying it is a non-responder, think about the source. It is the most counterfeited drug in the world. So ask them to get it from a reputed pharmacy. Alternate drug can be advised if it is not responding at the maximum dose for a period of 4 to 8 weeks. Then this drug doesn't act without stimulation. So adequate sexual stimulation should occur after taking this drug. Now Mr. Albert was having some psychological issues and he was taking mirtazapine. So what is your opinion about it? In fact, depression and ED has a multi-directional, complicated relationship. Depression increases the chance of ED and vice versa viciously. And daily issues aggravate both these conditions. And when we try to prescribe antidepressant for depression, when depression gets improved, ED improves, but due to the side effects of antidepressant, erectile dysfunction or sexual dysfunction can occur. So that is a different scenario, and two strategies are there. Either switch from a drug that causes erectile dysfunction like escitalopram, paroxetine, etc., to that one which causes least, that is a bupropion or mirtazapine, or do drug holidays if the depression is under very well controlled. But remember that depression is much more serious than erectile dysfunction. So Albert is also taking telmisartan. He wants to know whether that causes erectile dysfunction. So these are the drugs that supposedly cause erectile dysfunction. And the safest with regard to antihypertensive is either AC inhibitor or ARBs, which doesn't cause. So Albert can continue to take telmisartan. So how to manage medicine-induced ED? If there is strong association, consider alternate or else treat without changing the medicine. So the next question, do Albert need referral? He has to be referred to a psychiatrist if there is complicated mental health or severe psychological problems. Then he has to be referred to a psychologist, a cardiologist if the heart risk is high, endocrinologist if there is a testosterone deficiency, emergency department if there is a priapism, urologist if the first line therapy fails, or if there is a history of pelvic trauma or Peyronie's disease, that is plaques in the penis. This is for specialist, the second line and the third line. Now something about the testosterone deficiency. It is diagnosed when the testosterone is less than 300 with presence of symptoms. 2 morning samples should be taken, and that should be similar and less than 300. And the patient will be referred to an endocrinologist. Sex therapy is useful in following set of patients, and its beneficial effects are given below. Now, are they happy now, Mr. and Mrs. Albert? This is the current situation. I think they're happy. Now, the happy Albert now referred Mr. Colvin. He has a peculiar problem to Dr. Nadeem. And this is a problem. And this is how it is defined. And how did Nadeem treated him? This is a step 1. Do a comprehensive assessment, accurately diagnose, then accurately check the degree of ejaculatory control and the partner distress. And for that, we have a PEDT tool, that is premature ejaculation diagnostic tool. Score of more than 11 is suggestive. Then rule out ED and PE coexist. Then determine intravaginal ejaculatory latency time, that is the time from the penetration to ejaculation. Normally it is 5 minutes and not half an hour. Then take a detailed history, that is important for classification and treatment. Examination is low yielding but reassures the patient. And this is how you manage. Involve both the partner and the patient. Multimodal therapies advised based upon the classification reached. Treat TD first before treating PE. And this is the various type of PE based upon the clinical features: lifelong, acquired, subjective, variable, based upon the intravaginal ejaculation time, symptoms, control of over the ejaculation, the cause, and treatment varies according to the classification. These are the self-help measures that you can advise the patient. Coming to medical therapy, dapagliflozin specifically was discovered for this purpose, and is a short-acting SSRI, and it should be taken on demand 3 hours prior. SSRI has a side effect of delaying the ejaculation, and this side effect is utilized and it has to be taken daily. But the problem is that SSRI causes other sexual side effects like loss of libido and erectile dysfunction, so problems can occur. Tramadol can be used in refractory premature ejaculation. PD inhibitors have synergistic role with SSRIs. And topical agents are available, and when you advise them, ask them to use condoms, otherwise the partner won't thank you. So these are the behavioral therapy techniques that you can teach the patient to practice at home. Now, this is a case of Bobby. You can read for years. Now, the question is different. Why did Viagra fail? This is because the doctor hasn't taken a comprehensive assessment and the patient was having delayed ejaculation, not erectile dysfunction. So that is something different. So these are the other ejaculatory problems. So due to lack of time, I am not going into details. Now, Mr. Manish is suffering from low libido for the last 2 months after his transplant. You did a comprehensive assessment, and what could be the reason? So these are the reasons for low libido. And in case of Manish, it was due to the 5-alpha reductase finasteride that was prescribed by the doctor who did a hair transplant. So after stopping that drug, the libido was back again. Now some MCQs, whether you have learned something from me. Kick the odd man out. Any idea? What is this? This is the intravaginal ejaculatory latency time. It is 5 minutes. All the rest are diagnostic tools for erectile dysfunction or premature ejaculation. So what does XRI cause? All of the above. It causes loss of libido, erectile dysfunction, and delayed ejaculation. So what is false about? What is false? False about a tadalafil. It can be taken with regardless of the meal. Only sildenafil should be taken 1 hour prior in empty stomach, because fatty meal delays the absorption of sildenafil, not tadalafil. What is false about testosterone deficiency? What is the value? Should be less than 300. So I will stop with the quote from Tolstoy. These are my references. Thank you.
The oral presentation for the faculties is about to start in Hall D. I request Dr. B.S. Sharma, Dr. Ashwati Ji, and Dr. Mamta Shivananda to move to Hall D, the ground floor, for their oral presentations. I would like to welcome Dr. Bijay Raj for the session on speaking the language of care, communication skills for family physicians. Over to you, Anas sir.
It's my pleasure to introduce Dr. Bijay Raj to the audience. I think he needs very little introduction. He was the founder president of AFPI Kerala. He's presently working as a senior consultant family physician, Star Care Hospital, Calicut. Dr. Bijay Raj.
Thank you, Dr. Anand, and good morning, Dr. Rasik. Warm welcome to you all on my personal behalf. And it's a big honor that I was considered to replace our dear Professor Venkateshan from CMC Vellore, the head of department there, who could not make it due to some personal emergency. And I have taken over this topic, which is very, very vast. Actually, it's a topic of workshops which last about 4 hours or even a day or two. And being told to compress this topic into 20 minutes is a challenge in itself, especially when we are talking about something which has got so many subjective elements and which is the soul of our practice and our career, actually. I hope I'm able to do justice to this. So the communication has been increasingly important, or the skills have been increasingly getting importance in various fora, talks, etc. Usually the Western countries emphasize this quite a lot. We see quite a few people who pass the exams purely based on communication skills and not so much on knowledge. But for our candidates, usually from India, when we go for the international exams like MRCGP, we find that many of them fail to clear these exams because knowledge is not the problem. We are good with knowledge, basic knowledge, etc. But it's the approach or the communication which tends to tear us apart. Here's a question for you. Day-to-day life scenario probably for most of you. I'll go a bit fast because it's a vast topic. A 70-year-old lady comes to you with a son for follow-up with an oral mucosal biopsy report. The biopsy report shows squamous cell carcinoma. Now the son has hinted to you earlier that his mother should not be told about any sinister findings, since he does not want her to get upset or anxious. As a family doctor, what would you do? Now these are the usual 4 or 5 common options which come to our mind. You do not reveal the diagnosis to the mother as per the son's wishes. Second option, tell the son that you won't reveal the diagnosis to her, but the specialist will do it. Third option, ask the mother whether she would like to know the diagnosis and comply accordingly. Fourth option, tell the son that the patient has a right to know about the diagnosis and you are duty bound to reveal it, whether she accepts it or not, how she accepts it, up to her. And the last option is, tell the son to reveal the diagnosis to her once she is home after the consultation. Just see, okay, ask the mother whether she would like to know the diagnosis and comply accordingly. Yeah, okay, fair enough. Sometimes we don't have a clear yes or no answer to some situations. Next question, more easier actually. 35-year-old man comes to you with 2 HbA1c reports, demanding to know why your hospital lab is showing a value of 6.6, which puts him in the diabetic range, and another lab is showing a value of 6.3, which puts him in pre-diabetes. For the patient, this is a heaven and hell difference, diabetic or not diabetic. Now he's angry about the lab, obviously. He has never had history of diabetes before, although his lifestyle and family risk factors are there for diabetes. He demands an apology from you and the hospital. What would be your approach? Accept the error and apologize. I think this can happen sometimes. Offer a refund. I've seen this happen, isn't it? Direct him to the lab, offer retesting free of cost. Again, something which I also do sometimes. Verify whether both the labs have standardized and quality control protocols, and if okay, proceed to explain to the patient the reason for the slightly different values. Or offer referral to a diabetologist or an endocrinologist. And last option also happens many times. No need to give such patients too much time. No need to accept any mistake or apologize. Tell him to cool down. These things are common. Recheck HbA1c after 3 months from a good lab and review. Come on. See? Okay, fine. Okay. Verify whether both the labs have standardized and quality control protocols, and if okay, proceed to explain to the patient the reason for the slightly differing values. Okay. Now those who said C, who all said C? Okay. How many of us actually look at the labs whether they have quality control protocols? Okay. Any hands? See, this is the difference between what Dr. Anup was telling just a few minutes, expectation and reality. We know what is ideal, but in practice it doesn't happen. Okay? So these are the problems which we have to communicate and try and solve. We can't always get the ideal answer all the time for our patients. So studies have proven that good clinician communication does prevent malpractice suits. People can sue us, no? Like you put me at diabetes, even I don't have diabetes. In America and all, they can actually sue you for mental harassment. A patient who feels that the clinician listens to and understands him or her is not likely to sue that person, even if there is a bad outcome. So I had this like just 2 weeks back. I've been seeing a lady for the last so many years. She came with some, she has been having some anxiety and depression, etc. And she came with some tiredness and some headache, vague headache, lasting maybe about 1 week or so. I thought it's a normal headache. 2 months back, I had seen her with similar symptoms actually. And she came 2 weeks back. And actually, this turned out to be a intracranial lesion. It's a far aggressive brain tumor. And, but yet, they don't take it as a physician's fault or missed it or anything. They came to update me about the progress and findings and everything. And I was like thankful that they didn't do it. And probably it's got a lot to do with the way we communicated. That this is only a headache, like it's only been for 1 week. We'll watch out for 1, 2, 3, 4, 5 things. She turned up 2 weeks back with, with symptom. I thought my grandson is sitting in the back of the car and talking to me. The grandson was not in the car. It was an auditory hallucination. That raised a red flag. MRI showed this finding. Okay, saved. So, why do we need communication skills? Good interpersonal skills enhance compassion, enable the physician to dissect out the tangled mass of personal difficulties. Like this patient, I don't know whether the headache is because of insomnia, because of anxiety and depression, or because of the cold she had last week, or what. But it's that point where she mentioned that I thought my son was speaking to me. 1 or 2 words only. That's where. Had we been hurried and not allowed the patient to complete just those 4 or 5 words, we would have missed the entire thing. So it forms the core of functional disease. Okay? There is subjective disease and there is objective disease. But only when we listen or communicate properly, we'll be able to sort out what is physical and what is not physical. And sometimes psychological issues magnify the symptoms felt by the patient, which is because of an organic condition. Like in the previous examples, if we take, there is erectile dysfunction because of diabetes, there might be some coronary disease, there might be some painful ejaculation, whatever. But if the mindset is not right, all these symptoms will be felt in a magnified manner by the patient. And we all know that broken spirit underlies a great deal of problems we encounter in practice. It's mainly psychological. 70% of our problems can be just dealt with psychological proper approach. That explains why 70% of primary care in India is still delivered by quacks and not by qualified people. Why? Because we might not have the time to listen. We might be too busy diagnosing physical stuff, whereas they are the ones who take care of the psychological lacuna or the vacuum which is there in the patients or the family's minds. So these were common lines previously, like about 10-15 years back probably, but with increasing awareness among practitioners, these lines are coming down, like the doctor understands my disease but not my illness. Okay. And communicating your understanding as a practitioner of the patient's experience of the illness is one of the most important therapeutic techniques which we can use. That I understand that it is not just about diabetes or this pain, but it is about how it is affecting your life. I am looking into that aspect also when I am managing you. Just making patient understand this simple aspect can actually, I don't know, it's a placebo or whatever, but it's like a child fell down, hurt his knee, and the mother comes and just says it will be okay with a slight massage. Now, how therapeutic that is. The more we listen, the more patients understand. The process of interview often determines whether the therapeutic relationship will work or not. Same treatment on the prescription given by 2 different practitioners. Why does the patient feel happy with one and not so happy with the other? It's just about this. How much the patient think that the doctor understood about me. Interpersonal communication is equal to quality of the interaction. So interviews what we call now, the old terminology of history taking is slightly getting outdated. We are not outdated so far. We are still using history taking actually, but actually it is called as patient interview nowadays. It contains two steps. One is the content, proper content. What are you, who are you, how are you, etc. And then the process, how the data is collected. The content is the subject matter, what is being discussed, and process is about the navigation or the flow or the rapport of the consultation overall. There are three key elements in the first step. 3 R's: rapport, respect, and relationship. Build a good rapport, respect the patient's thoughts and concerns, and try to build a relationship. The physician should be an active participant, an active listener, but an observer during the interview process. Be very alert to the information being shared or being given. The patient is practically telling us the diagnosis in at least half the cases, but don't interrupt. Openness of the interview is further enhanced by mirroring the posture of the patient. So this is an important part in understanding and building rapport. If the patient is like closed, you can adopt the same posture. It's again a very vast different topic. I won't go into details of it. Unless the patient has got an aggressive body language, it's better not to mirror aggressive body languages, but open or closed body language can be mirrored safely. And the patient feels that, okay, we are on the same wavelength. It's a psychological subtle clue, but it works. The traditional model of history taking comprises this approach which we are all familiar with: name, age, sex, religion, address, occupation, whatever. But this kind of history taking is mostly one-sided. You know, the one person is asking, the other person is telling the answers. It's almost like an interrogation. And so patients also sometimes tell us, no, like, then the policy. So this is what happens. Now that ends with the history taking part also. Okay, you got the history, you got the diagnosis, this is a prescription, go. After that, what? That is what we call as like usual general practice. It does not translate into family medicine practice in the way. This is a bridge which connects what happens next. That's what's coming up. So we might be in various stages of practice. Some of us might be learning, some of us might be starting out, and some of us must be experienced. And with the internet coming up, patients also know what to expect when they meet a doctor in terms of communication also, not just about the diagnosis. And can anyone make sense out of this scene? Anyone seen this movie? One of the best movies with a legendary villain, but his interview is all about communication skills. The consultation is at the heart of family medicine, and we will look at some of the basics in quick flow. First step is initiating the meeting. Second step is gathering the information. Third step is the physical examination, followed by explanation of what you found, and then planning the treatment. And last part of the consultation is closing the session. That is where safety netting, etc. comes in. So there's a 3-stage assessment. Okay, the physical part, subjective part, and the planning and explanation part. There's something called as a golden minute, where the patient is encouraged to keep on talking. Studies have shown that about 18 to 20 seconds is the average time the patient gets to speak before the doctor tends to interrupt. And even if this patient is left alone to complete the side of the story, it rarely goes above 1 minute, 60 seconds. Okay. So it can be simplified. Like if you want to make something as simple as a consultation sound very complicated, we just have to go into the details of these concepts. There's a subjective element, the clinical part of the consultation, the individual perspective of the consultation, and the context of the consultation. I'm really running short of time, but I'll just take a minute to put it in example. Like subjective clinical means patient coming with tiredness and weight loss. Individual means the same. Contextual means he is an auto driver. He can't work right now. Objective is clinical. For example, this person would be having diabetes, which is uncontrolled, HbA1c 9, 10, 11, whatever. Individual is he wants to get this control and get back to work. Contextual is the treatment or the management, whatever, like the holistic part of it should not interfere with his work. It should allow him to function efficiently. Assessment here would be, clinical assessment is, this is unmanaged diabetes. We have to look for complications also. Individual would be, can this patient afford the tests and the medicines which you are giving him? And contextual will he be able to comply? And plan would be to discuss all these things out. this is your diabetes, this is the medicine I'm trying to give you, and I would like to give you some medicine which would not cause you hypoglycemia since you are an auto driver. The individual would be thinking that this person might not be able to afford a 15 rupee, 20 rupee tablet a day, so you have to look for alternatives which are cheaper, which will give him the same therapeutic benefit. And contextual would be to warn him about the minimal risk of hypoglycemia and being compliant about diet, exercise, timing of the food, etc. So this is how one chart can help us in ticking all the right boxes in a 10-minute consultation. I'm skipping a few slides because of lack of time. I've covered this also. Okay. So just this is another important slide. How do you initiate the session, the consultation? First, prepare. Like I usually, when I see a patient's name in my EMR, I don't have a very good memory, but I document things fairly elaborately, very fast. And when before they come, if I know that they have come, I just look at the EMR and see what they had come with the last time. Okay. That prepares me for the consultation. It's like otherwise when patients come and doctor, they come with a smile and I'm like, okay, I've seen them before, but I have no idea. That's a very awkward situation to be in. Preparing ourselves for what is going to come next by going through the records just before that. It's like, vanno, okay, that opens up the consultation like anything. Doctor, nalla control ആയിരുന്നു പക്ഷേ കഴിഞ്ഞ ആഴ്ച കല്യാണത്തിന് പോയി this time my sugars have come high. My HbA1c 7, it's okay, but my today's fasting is 200 etc. Immediately they're onto the point. Okay. So that's how you prepare, establish the initial rapport, identify the reason for consultation just like this time. In the example I mentioned, the reason for consultation was now sugars are raised and the patient is aware already that HbA1c is 7. So 3 months it was generally okay and it's definitely the marriage which spiked the sugars. Gather the information, exploration of the patient's problem to discover. What is a biomedical perspective? Uncontrolled sugars. What is a patient perspective? It raised because of the marriage which was there in the family and I'll be able to control it with some dietary modification most probably. What is the background information and the context? The context was obviously the marriage. That is gathering information. It is not just about uncontrolled sugars, hide the OAD or maybe wait for 2 weeks and come back. The context was very, very important here. Then the physical examination. Okay, it's a routine diabetic checkup, so let's start from the head to the feet, till the nails and in between the toes. Then explanation and planning. Okay, you think it's because of the marriage, but I think it is not just because of that. Maybe your weight has to come down a bit more. You're on 500 mg of metformin 2 times a day. Let's hike it to 1,500. It will also help you bring your HbA1c from 7, which is reasonably okay, to our ideal target of 6.5. Okay, so there's always some discussion to be done, even if you feel the patient feels that everything is fine. So it's shared decision making. If the patient agrees to hike the dose of metformin, okay. If not, encourage lifestyle and weight loss more. And closing the session, appropriate point of closure. That okay, this is what we have decided. X and Y Z test to be done after 3 months or 6 months, and please come back for your review. And watch out for complications, which are A, B, C, D, E, etc. That's called future planning. Okay, so understand the concerns. And perceived quality of time is critical to the patient experience. Patient might think we have spent, patient might feel doctor didn't give enough time, even though consultation was 15 minutes long. It happens with me very, very commonly. But actually, it's possible with some practice and with follow-up patients to spend just 5 minutes and make the patient feel that there was sufficient time given for that concern. It comes with practice. The listening environment should be calm, comforting. There should be active empathy from the practitioner's side, respectful, affirming that yes, I have understood what you are trying to tell me. Assess the patient's behaviors and responses, like Dr. Anup was saying in previous talk, that the patient left from the consultation but had something like a question mark when he was going to the door. Okay, hand on doorknob syndrome, it is called as. That patient's agenda has not been fulfilled. When the patient tries to go out of the OP but seems to take a pause before going out. Okay. There are a few other aspects, but obviously we're running short of time. I'm skipping a few slides. This is an important slide. Be careful not to lose the human being in the discussion of the disease. A person has a disease. The person is not the disease. Okay? A person is not a problem. The problem is the problem that he or she came to you with. Try to sort this out. There's a difference between them. So that's why we don't refer to them as case of or bed number or that appendix is going to be operated tomorrow or he's a psychiatric case. Especially we should not be saying that the patient is a psychiatric case because psychiatry is not a diagnosis. Psychiatry is the name of the specialty. Okay? The problem is anxiety, depression, stress, okay, bipolar disorder, etc., etc. Try to avoid jargon during the consultation process. It's not good to say that there is a thrombus over there which I have to refer to the neurologist who will get it thrombolized. Okay, this is one of the main reasons why the patient comes out, and when the bystander asks him what the doctor say, ഒന്നും മനസ്സിലായില്ല. Okay, the problem is jargon. So there are barriers also to this. We are always short of time, like I am in this talk. Vast things to discuss. Family practice, you have got 8-10 symptoms from the patient's side. You have got only 10 minutes or 15 minutes at the most. But you have to practice and try to keep it short. And technology is also a barrier to such effective communication because most of the time we are looking at the screen and typing. But after 1 or 2 visits, the patients understand that we are documenting it for our good and their good, both. Okay. And I think I'll skip a few slides and go to the last slide state. These are just a few examples of prescriptions. I just wanted to show this is an average patient of mine, all these 3 prescriptions. I hardly see any cough and cold. It's always complicated. But most of these consultations take about 15 minutes. It's not possible to communicate effectively and see more than 25-30 patients in a day for a competent family medicine practitioner. Anything above 50, quality is getting affected seriously. Anything above 30, quality is being affected. Whether we realize it or not, different story. Okay, so that's all. I think this is one common perception. But again, I won't fault doctors there because they have to see 100 patients in a day or more than that. And we only have to see maybe 25, 30, 40 in a day. It's all about time and awareness about how to communicate, how to approach it. Okay. So this is a good book by our own Dr. Hemant Saluja from Delhi. I think every PG should be reading it at least. Thank you so much. I think, is there a question and answer coming?
Thank you, Dr. Vijay. Regarding the first session,
Kindly request
by
Dr.
Dr.
Anup.
Anup, do we have any questions for the session by Dr. Anup? Or if there are any questions to Dr. Vijay Raj, please use this time.
So if there are no more questions, I think we would conclude the session. I would like to request the chairpersons to present a memento to Dr. Anup KJ and Dr. Vijay Raj. To present a token of gratitude to the chairpersons, I would like to invite Dr. Indu Rajiv, President of AFPI Kerala Chapter. I kindly request Dr. Abdul Razik and Dr. Anand to receive the memento. Thank you, ma'am, and thank you, chairperson.
Sorry, just an announcement. Let me request Dr. P.S. Sharma and Dr. Mamta Shivananda, who has registered for oral presentations, to please be reported in Hall D. Oral presentation is going on in Hall D. Please report in Hall D. Dr. P.S. Sharma and Dr. Mamta Shivananda. Thank you.
an important announcement. There will not be a separate tea break. It will be a working tea that will be served besides the main hall. And it will start in a few minutes' time.